All right, I have my Dexter sitting in the chair. His head is strapped to the headrest. I have adjusted the headrest so that his occlusal plane is parallel to the floor when his mouth is closed. I used the adjustment lever here to make sure the chair was as high as it can go so that my back doesn't get worn out. And then I've lifted up on it with my foot to lock the chair into place so that I don't accidentally swivel it as I'm leaving the room to take the exposure. For a bite wing, I have the plate in so that the letters are showing through the clear window, and the sticky tab is on the back side. If we're doing horizontal bite wings, the tab is placed in this direction. If we were to be doing vertical bite wings for a perio patient, we would need to have put the tab on the opposite direction so that when the patient bites, the plate would be in the mouth this way. But for today, I'm doing horizontal bite wings. I'm going to start with the molar exposure. And I'm working one-handed, so forgive me. First look in the mouth, and he does have third molars that are through the gums. With a bite wing, you just need to get the teeth that are erupted through the gums. We don't worry about unerupted teeth on bite wings because bite wings are to look for decay primarily, and you can't really have a cavity on a tooth that hasn't even erupted yet. So we make sure we push the molar shot all the way back so that the distal edge of the film, the part back here by the throat, is at least a couple of millimeters more distal than that third molar there. Hard to focus. And then with my other hand, I will use the lever to have him bite down there. If you look at the tab is in the very center of the plate. So the tab should be positioned on the teeth that we want in the very center of the plate. So he is biting on the tab using his second and even his third molars. So I know for sure that that third molar is going to show up on this image because it is the third molars and second molars I can see biting on the tab itself. So I know I'm going to be far back enough with my image. While you're getting the hang of visualizing your angulations, I suggest you get a cotton swab and tape it in the 3 to 9 o'clock in the horizontal plane against the end of your PID so that you have a really easy visual of how your PID is angled in the horizontal plane. For your vertical angulation on bite wings only, you always want this dial to be set to 10 degrees down. So you'll be at the 10 degrees below the 0 here. For periapicals, this is not the case, but for bite wings, this is where we always want our vertical angulation to be set for all bite wings. Now, after I have my vertical angulation set, the next thing I'm going to do is to line it up pretty close so that my PID is completely surrounding the tab so that the entire plate will be exposed to the radiation coming out of here. We don't want to have this up too high or too low so that we miss part of the plate. We want the entire plate to be covered by the end of this PID. There's a couple of ways to do that. If you can visually see the tab, if the patient can smile with their lips, you can ensure, looking at the tab, that the tab is in the very center of this round opening. If that's not possible, then as long as you put the tab, the plate, in the mouth in the correct spot, we can use some landmarks to help us see that. If you stand directly behind the tube head, this line for a molar shot should point to the outer corner of the eye. So I should move it back a little bit. And if we look from the front, this line, which divides the tube head in half from top to bottom, should point right at the occlusal plane. We want half of the cone to be on the maxilla and half of it to be on the bottom. Sometimes these cones are put on a little bit crooked. But to me it looks like I have a little bit more of my PID on the maxilla than I do on the bottom. So I'm going to have to scooch the whole thing down just a little bit. There we go. Now the plate in the mouth is centered in the very middle of my cone. My point of entry is correct. Now we have to make sure our angulations are correct. We already have 10 degrees down, so vertical is good. But if we don't get our horizontal angulation correct, then we're going to have closed contacts. And with bite wings, it's critical to have open contacts. If you look at the end of the tab, it should be running parallel with the molars, the buccal surfaces of the molars, as long as I put my plate in parallel with the arch. If you can't see the tab, or if the plate is inside the mouth a little bit crooked, then you need to look at the buccal surfaces of the teeth themselves. And it's a little shadowy with my phone here, but while you're trying to get the hang of this, you can use another cotton swab and make a bridge over the first, second, and third molars, trying to contact all three buccal surfaces, and that will show you the horizontal plane that those teeth are aligned in. And then you would need to adjust the tube head so that both of your sticks run parallel with each other. I'm not too far off, as you can see, but this cotton swab here is running at a little bit more of an angle than my tube head angle is, so I'm going to adjust that. All right, I swiveled the tube head to adjust the horizontal angulation so that both of my sticks are running parallel with one another. Now, anytime you change the horizontal angulation, if you watch, if I change the horizontal angulation, I have now completely changed the point of entry to my beam, and I'm not going to have the plate centered inside the cone anymore. So anytime you swivel this horizontally, your point of entry changes with where the beam is going to actually enter the patient's tissue. And even though I had originally centered the plate in the middle of this cone, because I swiveled it, I'm going to have to double check and recenter it to make sure that that tab is still in the very middle of my cone. After you have your horizontal angulation set just how you want it, if you realize you need to move either back or forward to avoid cone cutting, grab your machine up here above the swivel joint, and you can move it around without it affecting your horizontal angulation that you had just set. All right, so my point of entry is centered over the plate again. My horizontal angulation, the end of this cone beam, is parallel to the buccal surfaces of the molars, which means the beam is running perpendicular to the molars, so it's going to pass right through the contact without any overlap. If I were to stand behind the tube head, this would be lined up right below the corner of the eye. Another neat trick that a lot of people find useful in helping to determine correct vertical or horizontal angulation is as long as your patient has a normal arch form. If you're taking a molar bite wing and you imagine the beam passing all the way through the patient, it should come out the opposite ear, right in the center of their ear. If your patient has a super narrow arch or a very wide arch, that little trick is not going to work. But especially if your patient has had ortho, so they have the proper arch form, that trick of imagining the beam exiting the opposite ear is a useful trick. Now we're going to do a premolar shot. An important note to remember is that when you're looking at the plate from this back side, the plate is not as big as the wrapper makes it look like it is. So even if your wrapper goes far enough back or far enough forward, you need to remember that your plate isn't going that far back or that far forward, and take that into account when determining if you have the proper placement or not. With a premolar shot, we need to get the distal 1/2 of the canine and then everything posterior from that fits on this plate. So we'll have the distal half of the canine, we'll have both premolars, and because premolars are so little, we're going to have some molars going on in there also. There's plenty of room for the molars to fit in with the premolars. So in order to make sure I get the premolars and the distal half of the canine, I'm going to need to pull this film as far anterior as I can. It will actually almost bend against the lingual surface of the patient's alveolar bone. You should start to see it curve along the arch. If you can get the canine cusp to be biting on the tab, then you're certain that at least half of that canine is going to show up on our plate. All right, so the canine is biting a little bit on the tab, so I should see at least half of that tooth on the plate once we expose it and run it through the scanner. Now, if you look at the end of my tab and compare it to the angulation of the premolars, because this is a premolar shot now, My tab is actually running pretty close to the angle of the arch, but it's angled a little bit more than the teeth are. That's because when I was hugging these anterior teeth, trying to pull it way anterior to get the canine, it kind of makes the plate more angled than the premolar teeth are inside the arch. So in this case, I'm not going to line my PID up with the tab. I'm going to make sure I focus on the teeth when I'm determining my horizontal angulation. This is a big hang-up for most students with premolar bite wings and even premolar periapicals. They will look at their film holder or their tab to determine their horizontal angulation instead of remembering to look at the teeth themselves. So let's see if I can get this stick to balance here. All right, so this cotton swab is showing us the proper horizontal angulation to get the contact points open on our film between the premolars and between the premolar and the canine. So I'm going to bring my tube head up close to the patient and initially try to center that tab in the middle of the cone as much as possible. With the premolars, it's much more likely that the patient will be able to smile and you'll be able to see the tab and make sure that it's right in the center of your PID. Otherwise, the trick is, in order to avoid cone cutting, when you stand directly behind your tube head, this line should point right below the pupil if our patient's eyes were open. And then, looking from the front, half of our cone should be on the maxilla and half of it should be on the mandible. So I would need to scoot this down. Now my point of entry is correct, meaning my cone is completely surrounding the plate and I'm not going to cut off any of the corners. Our vertical angulation was already set to 10, so we're good there. Now we need to fine-tune our horizontal angulation. My sticks are almost parallel with one another. And it might seem like a very, very minor change, but look how big of a difference I have to change to make them parallel. So since I changed my horizontal angulation, my point of entry, the beam has gone from hitting the patient here to hitting the patient here. So I might be at risk for cone cutting the back of the plate inside of the mouth because this might not be completely centered around the plate on all four sides. So you're gonna have to double check. As you can see, I'm no longer pointing right below the pupil. I'm now pointing to the tragus of the nose. So I need to move the tube head distally again without changing the horizontal angulation I just solidified with my sticks. So I'm going to grab the machine up here above the swivel point, and I'm going to shift the whole tube head distally a little bit so that I'm behind, right underneath where the pupil would be if the patient's eyes were open. And that should not have changed my horizontal angulation at all. Double check that half is on the maxilla, half is on the mandible. All right. And remember that ear trick I talked about a minute ago? If the patient has a normal arch shape, if you imagine this beam going all the way through the patient, it should still be exiting the patient's ear, even though we've come around the arch and we're now angling slightly more towards the throat than we were for the molar shot. Anywhere you come, whether it's a molar shot or a premolar shot, any way you come around with the beam, if the patient has a normal arch shape, it will look like the beam is going to pass out the opposite ear. "95% of the bite wings you take, you will use the tabs for because you need to become very proficient at using tabs and not relying on a beam alignment device. However, we do have these in clinic and you will be required to use them for one of your Dexter assignments just so that we are sure you are familiar with how they work and you know how to use them. For the beam alignment devices that we use for bite wings are called flip rays, and they can be used for either horizontal or vertical. To use it for a vertical, you would simply rotate this bite block end. Hard to do one-handed. Sorry, guys. And then that would hold your plate in a vertical position when your patient is biting on it. But we're going to be demonstrating horizontal, so I'm going to go ahead and rotate that back around. All right. Now when you look through the target, you should not see the letters. You see how it literally says opposite side towards the tube head? When you are looking through the target, you're pretending that your eyes are the tube head, so you should not be seeing those words telling you that you should be looking at the opposite side. So I'm going to flip it around so that the letters are facing the other. All right, this is correct. If we had taken it the other way, we would have had a mirror image. You just place this in the mouth. For a molar shot, you're going to go all the way as far back as you can. Make sure that the plate goes further back than the most distal erupted tooth in the arch. And then you'd ask the patient to gently bite down on the holder. You then slide carefully without changing the film's position. The ring as close to the patient as you can. And now I can take this off because all I need to do is align the cone with the ring, making sure that it is parallel to the ring all the way around the top and the sides. It doesn't have to be contacting the ring, but any gap between the cone and the ring should be the same size gap going all the way around so that they're parallel with one another. And this also will prevent cone cutting. As long as you placed the film in the correct place in the mouth and at the correct angle, this ring is a really good guide for not only your horizontal angulation, but also for your point of entry to avoid cone cutting. Now for the premolar, you remember how it can be tricky to get the canine in the shot, and we have to pull it really tight against the anteriors, almost bending the film a little against the bone. That often causes the plate to be angled across the floor of the mouth like this, instead of running parallel to the premolars like this. So this is demonstrating the plate running parallel to the premolars. However, I'm not anterior enough with the plate. I'm going to miss the distal of the canine. To get the distal of the canine, I have to angle the plate more than the angle of the arch in the horizontal plane. They're not equidistant. You can see that the plate is touching the molars, but the plate is quite far away from the canine in the anterior. If it were parallel, the distal half of the plate would be the same distance away from the molars as the anterior portion of the plate is away from the canine. So we have two options. I can either swing the distal of, if you watch the distal portion of my plate there, I can either push on the tongue with it so that my plate is equidistant from all of the teeth. The problem with that is patients will usually push it back over again with their tongue when they bite down. So a lot of times there really is no way to avoid this overangulation of the plate in the horizontal plane. I'm going to pause here and bite him down. And again, this is where most students get frustrated because they get overlapping on the premolar shots, whether it's a bite wing or a periapical. So if I were just to line, I'm going to assume that the ring is accurate. You know what happens when we assume. I'm going to line up my cone. I'm going to take my shot, and then I'm going to wonder why in the world my contacts were overlapped. Well, this ring is lying to me because of how severely I had to angle the plate in order to get that canine included. If you use your cotton swab again, let me get this out of our visual here, you'll see that this is the angle of my premolars. Make a bridge over the two premolars with your cotton. If I move this ring back in, my cotton swab and my ring are at two very, very, very different horizontal angulations. I need to be matching the cotton swab, not the ring. I need to make sure my beam is going through the teeth, through the contacts, regardless of what the ring is showing me. The ring only indicates where the film is inside the mouth. The ring doesn't indicate the angle of the teeth unless your film is running parallel with the angle of the teeth. So if you're able to put the film in properly, meaning it's completely parallel with the teeth horizontally, then your ring is accurate. If you know that your angle of the film is not the same as the angle of the arch, then you're going to have to either take the ring off Or if you're good at visualization, you can just kind of ignore the ring and match your tube head, your cone angle to be parallel with the angle of the teeth. And for the first semester, at least working in lab with Dexter, you're going to want to use cotton swabs. You can use the cotton swabs with humans if you need to, but the goal is definitely to wean you guys off of the cotton swabs as much as we can. So if this is too distracting to have this ring in here like that, I would recommend just sliding it off. You can just use the stick and the bite block as a firmer block compared to the tabs that can kind of tear easily. And then it might be easier to visualize the correct horizontal angulation without that ring getting in your way. Then you just need to make sure you're not cone cutting. So half of it's on the maxilla, half of it's on the mandible. It's a premolar shot. So my line should be right under the pupil. If I stand behind my tube head, that's how I make sure my point of entry is right in the middle of my plate. And if I use the ear trick, it would look like the beam is exiting out the opposite ear on the other side. So this would give us a really good bite wing, whereas if I had gone with the original angulation that my beam alignment device tried to show me, this contact here would be open, the contact between the lateral and the canine, and then it would get progressively more overlapped the further posterior I went.